To some extent, you may have already answered my next question, but it's a question that I've been asked by others to ask you. Is there a difference between best practice and ethics? And if so, what is that difference? Any volunteers? Professor Kerridge.
Look, I think it actually goes to probably the first question that Julian responded to this morning, which was the difference between evidence and ethics. I mean, best practice can be determined purely on factual grounds if you want. How that applies to individuals will then have to take into account ethics. That will be decisions made by the individual about whether they will accept the recommended best practice. If you want, and best practice can be determined on the basis of epidemiological data derived from thousands or tens of thousands or hundred thousands of people. How it applies to an individual and how it's applied to populations in different settings will be a matter of ethics, but best practice is distinct.
And sorry, Professor Savaleski.
I would say that best practice is defined by the profession. And ethics is separate to that. So, I think practice is always evolving, and in addition to Ian's considerations, the ethical norms and standards change. So, best practice is typically what the profession defines as best practice, and ethics need not be equivalent to that.
Do clinicians... Oh, sorry, Professor Fossides.
Yeah. I just wanted to add that increasingly best practice is driven by protocols, and we would hope that in developing those protocols, ethical principles are referred to as well as scientific and medical. But I agree with Ian and Julian that the application of best practice standards requires thinking on the feet about ethics.
And do clinicians owe the same ethical obligations to all patients, or do obligations differ based upon the particular patient?
I'm happy to have a go at that. I think very clearly they have different obligations. In part, that's because patients are different. They have different goals, aspirations, needs, values, desires, relationships, social determinants, social context. So they will value things differently, and they may make different decisions on the basis of different information or even the same information. And that will determine the way that physician behaves and the types of things they say, the types of information they give, and the types of decisions they come to jointly with the patient. But they also differ because clinicians will have particular relationships with particular patients, and they won't have that same kind of relationship with others. So they'll have a stronger duty, a stronger obligation to a patient who is involved in their they're involved in their care, and they will have a lesser obligation to a patient they don't know of, a patient whose care they're not responsible for, and so forth.
Can I add just one thing to that? So sometimes there's a distinction between rationing decisions and bedside decisions. So rationing decisions or decisions about what treatments to make available to different groups of patients are best not made at the bedside. They're best made at a higher level. And the basic principle should be the doctor should be concerned to promote the best interests of his or her patient, rather than trying to make these rationing decisions at the bedside. There are interface cases, such as intensive care, where a doctor may have to withdraw treatment from one patient in order for another patient to enter intensive care. And that involves decisions not just about the immediate patients, but very proximal patients. But in general, my view is that the rationing or distributive justice decisions are best made through policy discussion at a higher level than the bedside, and doctors should in general be concerned to use whatever is available to them to do what's best for their particular patient.
Professor Kay.
Sorry, Bobby.
The advantage of that is that it maintains the trust in that one-to-one doctor-patient relationship, because it does allow the doctor to sort of forefront their attempts to do the best and act in the best interest of their patient, knowing that there are these constraints that have been set at a higher level.
Just to add, I agree with everything that's been said so far, and the duty is certainly dependent on the facts, but there is also a duty to act fairly and to avoid discrimination.
So would it be right to understand it this way, that the same core values that you identified in your discussions before the break may apply to all patients? No one patient is more deserving of respect for autonomy than another, presumably, but the way in which those values interact and are weighed, and the way in which a clinician shows respect for a patient's autonomy may vary dependent upon the relationship, the particular patient, and so on. Is that correct?
Yes, and the context as well, I think.
I think. Sorry.
You talked in terms of basically one doctor, one clinician, and the patient, and the doctor making a decision which he thinks is the best decision together with the patient. But where a doctor operates, as perhaps more and more doctors do in practical medicine, as part of a team, to what extent is it a team decision, and what happens if members of the team don't take quite the same viewpoint?
That's a wonderful question. Sorry, Julian, you go.
Well, no, you're probably better placed to answer this because you're at the coalface. But my understanding of clinical care is that one doctor has to take responsibility. Now, that doctor may be a member of the team and will need to consult with the team, but in the end, the buck stops with one person, and that person may be a part of a team, but there may be disagreement. And I've also written a paper defending dissensus rather than consensus. And sometimes in medicine, consensus isn't possible or even desirable, but what you need are reasons. And the job of the person who is responsible is to listen to the evidence and the arguments and to come up with what they believe is in the best interests of this particular patient. Ian, would you agree with that?
I would. I mean, so Brian, things have changed quite substantially, and as you say, not only patients are now unquestionably cared for by large teams, and very, very large teams of involving a range of health professional and allied health professionals, data managers, all sorts of things. Research scientists, if they're involved in research as well, sort of groups of individuals involved in care that we couldn't have imagined, 10, 15 years ago. So that's the first thing. The second thing is that there are now areas of practice where it's mandated that there has to be a decision about best practice made not by the individual doctor anymore, including the doctor who's in charge of that patient, but by a multidisciplinary team and through a multidisciplinary team meeting. So in the area that I work in, for example, in relation to blood cancers, is that it's required that at diagnosis, at progression, at completion of treatment, all of that patient's data has to go back to a multidisciplinary team, and there has to be agreement about the appropriate steps forward. And that's in many ways quite onerous, but it's a significant change in the responsibility of care. So I think it's true what Julian says is that there is a team, and there may be an individual there who's primarily responsible and who primarily has the core relationship with the patient, but there is a range of people involved. The only other thing I'd say, though, is that when there are teams, not only do you need to have processes for resolving disagreement, because it's appropriate and realistic that people will disagree when there are large teams who bring different values to the table in relation to a patient's care. But I think you need to also have structures and processes that allow for disagreement and disputation. So advocacy involves, it's a legal concept that applies to medicine and ethics, but that involves somebody talking for an individual against someone else. So I would argue that there are times when it's the nurse should advocate for the patient against the doctor. The doctor could advocate against the physiotherapist. The physiotherapist could advocate for the patients against the entire rest of the team. And it's through that process of disagreement and consensus, both of those things, that arguably good practice occurs.
And would you agree that the multidisciplinary team has extended to the extent sometimes that the patient themselves is invited into that context to hear discussions and contribute? And that's one point. But the other is I very much agree with Julian that disagreement within a well-functioning team is very protective. Because it allows issues to be discussed and debated, and it plays against sort of traditional power structures that might have meant that what the chief consultant says goes. So what you need to do is facilitate and support particularly junior members and members of allied professions in having a role in working out what's going to happen in a particular unit, what the policies are going to be.
Yeah, absolutely. But Bobby, I completely agree with your comments about teams, but there's an interesting aspect to teams and to multidisciplinary team processes of decision making and care, is that on the one hand, there is some evidence that it improves things like cancer outcomes. But on the other hand, and Emma, I'm sure, would know the cases because they're principally from the United Kingdom, there's many cases, particularly involving children, where care has been compromised, in fact, by emphasis on team and by nobody actually being primarily responsible for the care of that particular individual. And that's a phenomenon that's been noticed in a whole range of areas of medicine, the emergence of the team and the collapse of individual relationships with patients in ways that can actually be detrimental. That's the response to that has equally been interesting. It's to come up with another professional group, which is the care coordinator. I would argue that another approach is to re-emphasise relationships and personal obligations rather than just create another professional group. But teamwork can be problematic.
Professor
I
Kane.
can just add that the GMC, in its latest guidance, 2020 guidance on informed consent, for the first time makes reference to clinical ethics committees and the fact that if there's disagreement between the team and the patient, that a clinical ethics committee is the way forward to try and help resolve that disagreement.
Thank you. And we'll come back to that guidance. Professor.
Oh, sorry, I just wanted to add on the clinical ethics committee. I helped establish one in Oxford in the mid-90s and have been involved with them. I think clinical ethics committees can be very helpful, but ultimately they should be advisory and the responsibility should be with the clinician in charge. So again, it's like a multidisciplinary team. You want advice, you want input, but somebody has to take responsibility for the decision. And I don't think that it's best invested in a clinical ethics committee to decide. I know you weren't proposing that, but sometimes people think, well, we should send this to the clinical ethics committee to decide. And I think that's a mistake.
Just to be clear, I agree with that. Advisory role, not a decisional role.
Absolutely.
I come on to ask you a little about what you say in your report about harms and wrongs. Now, legal wrongs are relatively well defined and well recognised. Your report suggests that ethics recognises harms and wrongs and injustice that go beyond established legal wrongs, so unjust treatment and moral wrongs. I wondered if you could elaborate upon that for us, perhaps starting with you, Professor Phossides.
I think the distinction that we were trying to draw was where someone may be wronged and may be harmed without knowledge of either. Or they may be wronged and something may intervene to protect them from the harm that might ordinarily follow, but that doesn't get rid of the moral wrong that has been done. So if we wrong someone, we behave towards them in a way that doesn't show respect for these fundamental principles and values that we have agreed on or imported into the particular context in which we're working. Maybe we have wronged them by failing to share with them the fact that we think these values and principles are important and should be upheld. Or maybe we wrong people because we allow them to continue in a very trusting relationship with us that makes assumptions about how we behave that we couldn't actually defend if it was called into question. Once we have wronged somebody, then there is very often the potential for also harming them, be that physically, psychologically, emotionally, or dare I say existentially. There is a sense in which a harm will probably follow a wrong. But as a philosopher, you are interested in thinking about anticipating the possibility of these things happening and looking for them in a different way to the lawyer who is required to provide the evidence that would support a claim of negligence or battery or one of the other issues that have been set out in the report.
Professor Kay.
Well, we also wanted to be clear about the range of harms and wrongs. I mean, you asked us to focus on the wrongs and harms to patients in particular, but we did want to make clear that there are also a range of other harms that are relevant here, particularly to family members, to society, and potentially also to clinicians, if, for example, they aren't given sufficient guidance or resources to be able to make the patient their first concern. And this is something we see, for example, in the COVID-19 crisis, where there have been calls for more guidance about ventilators and who should get them if resources are limited, and to an extent that hasn't happened as yet. So it's not something that was just sort of limited to the past, it's something that we see today too.
And you talk in your report about a concept of a denial of an open future. And I wondered, again, perhaps I'd direct this in the first instance to you, Professor Farsides, whether you could explain a little more about that concept.
Yes, this is a concept that was originally associated with a particular philosopher, Joel Feinberg, and he was actually talking in the first instance about children. But I think the idea of an open future can also relate to us talking about adults, because the idea is that in treating somebody in the present, particularly an autonomous individual who has clearly got projects and goals that they wish to pursue in their future, the decisions you make on their behalf or the decisions you remove from them could have implications for how open their future is, i.e. how able they are to fulfill and address those goals and ambitions, which may be as ordinary as living a long, happy life, or maybe very specific and address, very particular abilities that they wish to maintain or develop. So I think one of my colleagues has already mentioned the concept of human flourishing, and it is one of the huge advantages we have as human beings, that if society is set up in such a way as to allow it, we will flourish, we will develop, we will have things we wish to do in the future that we may not even know about or recognize now, but will require us to have been treated in a particular way in the past, so that, for example, we can make best use of the educational possibilities that are available to us, and don't spend a lot of our childhood, hospitalised or such like. So it really is this idea that, yes, we often have, in the extreme case, medical emergencies. And many medical decisions appear to be very much of the moment. But we know, particularly in chronic and lifelong complaints, we make decisions today that could have implications a long time into the future. And a good example of how we've come to recognise and address that would be in our treatment of children in a paediatric oncology setting, where we think much earlier than they themselves might do about their fertility and how we might be able to preserve that in years to come.
Can I add one qualification to what Bobby said? And I completely agree with everything that she said. Essentially, the open future argument is that we should choose options which keep options open for people, so they've got maximum choice for themselves in the future. And I think that's right, we should do that. But sometimes we're faced with choices that just involve different options. They close off some but open others. And this open future argument can be misapplied. So one classic example is assignment of sex to children born with intersex conditions. These are children who are ambiguous between male and female. And historically, the medical decision was to fashion anatomically a female because they could achieve a better functional outcome. So children in this condition were surgically operated on soon after birth and made into anatomically female. And many years later, many of them objected and said, we should have been left to make that decision ourselves. And the open future argument has been used to support that, to say, look, you know, they should have been left with the options of remaining as they are or choosing the sex they want to be when they're able to decide. And I think they should have been left in that way, having done a project on this. But I don't think the open future argument supports it. And the reason for that is that there are two different trajectories. There's a trajectory with a certain psychological environment as you grow up, with a determinate sex where parents accept you in one way, society accepts you in one way, versus a different psychological trajectory with different anatomical options. They're different options. And I agree with the intersex community that the second is a better option, but it's not necessarily because it's got more choices. It's got more choices in one way, but you can't undo the psychological trajectory. And that was the reason why doctors did those practices in the past, which they now do less. So the point of the example is to say sometimes we just have different options and we don't have more options and better options in just one arm of the choice.
Could I also add to that? I think the principal idea behind the open futures is and I think the argument's changed a little bit over time. It started with issues of fertility in children and genetics and very much long-term future possibilities. But the issue is really that the choices made or the assumptions made by doctors will cut off or determine the options available for people in the future. And that future can be fairly short-term or it can be very long-term. So, and it doesn't necessarily be all options, it can be just very specific options. And an example, again, from my practice is that if you fail to tell somebody that they are dying, whether they're dying within sort of days or weeks or months, but if you just neglect to do that because you're concerned that that will be damaging to them or because that's not something that they need to hear in specific terms or because they would know that in any case. But if that's not addressed, then that may deprive people of the opportunity to say farewells, to ask forgiveness, to complete a will, a whole series of things that are immensely harmful to people and can be the source of enormous grievance when they find out that actually you knew a good way ago that they were actually dying, but you didn't come out and say this. So it's a decision or an assumption made by a doctor that limits the choices or the options that are open to somebody into the future.
And I think one of the positive side effects of having this sense of an open future in your mind is that you give attention to the particulars of the patient in front of you, and also increasingly, hopefully, learn from the amazing growing literature around patient experience and illness narratives more generally that might give us more of a starting point to have conversations about these issues than would have been the case in the past, because whilst you don't know immediately what a particular patient's future would look like to them if they had had the choice, we do have a growing sense of patients over generations telling us about what it has meant to live with particular conditions, or as Ian says, live with life-threatening or life-limiting conditions.
You identify in your report still in the discussion about harm, three important factors in particular from an ethical perspective when harm befalls a patient. And you've identified them, and it's the bottom of page 9 of your report for anyone who's looking at the document. Responsibility must be attributed in order to ensure appropriate action is taken to prevent further harm and understand who should offer explanation, apology and redress. Openness and transparency are needed to ensure lessons can be learnt, and so the person harmed can assess the actions taken, understand their experience fully and pursue further action if necessary. And thirdly, recognition is required so that those responsible for the harm can understand its nature and the impact it will have had on the persons harmed. I wanted to ask you if you're able to elaborate upon those three factors a little, and in particular the third, which may be less obvious than the first two. And I don't know who would wish to dive in first in that regard.
Shall I have a go?
Yes, please.
Okay. I suppose if we were looking for a policy that we have now developed in healthcare settings that would bring these three things together, it would be put under the heading of a duty of candour. And that tells us that if and when something goes wrong, which is possibly what has happened when a harm has befallen a patient or group of patients, then we wish to investigate and learn from that in order to prevent future harms. And it goes back to Julian's point that even if we say there was a complex team involved here, we want to be able to go somewhere to someone to almost hold responsibility for engaging with us in that learning process and working with us to try and ensure that systems or organisations and the behaviour of individuals will be different in future. The second point is about, sorry, could you repeat the words again for me so I'm clear I'm accurate?
Yes, so the first point was about the attribution of responsibility.
Yeah.
The second was openness and transparency for lessons to be learnt. And the third was recognition so that those responsible for the harm can understand its nature and the impact it would have had.
Right. So the implicit in what I've just said is a requirement for openness and transparency, because we won't learn the proper facts of the matter if people are being defensive or hiding things, or even not taking it seriously enough to dig down and find the important information. I think the final point, it goes two ways, and we've emphasised here probably the more unusual one, which is that in acknowledging that mistakes have happened, you reflect upon your own practice, your own values. You think about maybe, for example, the extent to which institutional pressures made you unable to act in a different way, or you think very clearly about what you personally could have done differently, may have done better. And why that's important is it makes it a genuinely moral response to the question, because we know things have evolved to the extent that legally and professionally there are benefits to be had from being open and transparent. But if you just say the words and don't acknowledge the extent to which what has happened reflects a failure and own that failure to some extent, then it's, in ethical terms, a job half done.
Could I add just, oh, sorry, Emma, would you like to go?
Okay, thank you. Yes, I just wanted to add that overall, this is recognition of the fact that mistakes are inevitable. Mistakes will happen because humans are fallible. And that what's really important is that we learn from these mistakes and that we try as far as is possible to put things right. And that's never going to be, you're never going to be able to put them literally back in the position they were in, but as far as we can to put things right. And there have been many reforms over the years that have tried to make sure that the system is better at doing these things. And they've only been partially acceptable and useful, as we see in the recent Cumberledge report, which made clear that patients weren't listened to in the context of certain medical devices and medicines, and that patient safety wasn't put first. So, though we have learnt a lot over time about how to do this better, there is still more to do.
Could I add just one thing? So when I think about harm, I think about two concepts, which I think are manifest in these three. The first one is moral responsibility, which is a function of two things: the foreseeability of the consequence and the avoidability of the consequence, or as Aristotle said, the knowledge and control criteria. So could you foresee that bad outcome could have occurred, and could you have avoided it? And the second one is blame, which is a function of the degree of moral responsibility and the degree of harm. And recognition is really about either other people blaming you or you blaming yourself. And blame is also a central concept that's important in our moral repertoire. But whenever I start with harm, I then ask, is somebody morally responsible? And then to what degree are they blameworthy?
Dr. Kazarian, was there anything you wanted
to add to that? Oh, sorry. Just that I think these ethical principles of responsibility, openness and transparency and recognition are important because they apply not only to situations where there's a harm, but also where there's an error without harm. And in fact, increasingly the healthcare system deals with those two things in an equivalent way now as part of the quality and safety movement that's a big part of healthcare. Is that if there's an error, and it could be a simple thing, simple medication error, of which the patient's just not aware at all, there's still now an expectation that someone will go to the patient and they'll explain what's happened, they'll explain why it's important, what steps have been put in place to deal with it, and whose responsibility it was. And invariably that goes really, really well. The other thing is that it applies outside of health as well. So these same principles apply in areas of politics and civil institutional care. For example, in the health policy or political arena surrounding Indigenous peoples and the care of children in institutional care, the sexual abuse of people by members of the clergy. I mean, the key ethical principles here in acknowledging this were recognition and acknowledgement, were an apology, were openness and transparency, and were responsibility. And that's when ethics is incredibly profound, is when it has resonance well beyond health.
Dr. Kazarian, was there anything you wanted to add on this issue?
Yes, I think there will be some things here that will link to what we explore in more depth later. But these three principles are interesting because they are both ethical principles and ethical duties that doctors and medical institutions have to respect. But some of them are also now in the law, and in particular, the duty of candor is now a legal requirement since recently. And that's because we've seen over the years that there have been different healthcare scandals, healthcare failing episodes where the medical profession or medical institutions more generally were not open and transparent with patients about what had happened. And therefore, it was important to recognize this in the law and make this a legal requirement. And I think the purposes of this is not only to learn about mishaps and errors so that we make medicine more safe or medical institutions more safer, but it's also about providing the patient, the individual patient, with openness and a way to come to terms with what has happened, and a way to provide them with some sort of closure and explanation. Because sometimes patients are sort of remote to the decision-making process, especially when teams are involved, and especially when care is complicated and decisions have to be made quite quickly as well. So it's important for patients to understand what has happened to them, and that's why those three principles are very, very important in medical ethics, but also now in the law, and I think we'll explore that more fully later on.
I think Dr. Cazzaro makes a really important point there, but just to build on it slightly, one of the problems we have in our system is that we have a system of negligence based on fault. So given that system and that fault needs to be proved, that there is also an incentive to keep things quiet, because this potential of a negligence suit hangs like the sword of Damocles. Other systems, such as in New Zealand, for example, there is a no-fault compensation system which tries to move beyond this and put even more emphasis on openness and transparency and apologies and redress.
Could I just,
yes.
and I know we're going on about this issue a little bit, but it's so important. It's, as Emma's mentioned, there are these perverse incentives to actually obscure these kinds of harms, these kinds of errors that have occurred. Wonderful example is the recent exposure of the amount of harm done by transvaginal mesh around the world. This was clearly a regulatory failure. No one disputes that, I think. And in a number of countries, including the UK, there was issues of regulation of new products that applied here. But if you actually go to the testimonies of the women harmed by transvaginal mesh, is what they say is that no one heard my concerns about pain. No one listened to me when I said I felt there was something wrong. No one acknowledged that there was a problem here, or that there'd been a misapplication of technology from one sphere of surgery to another sphere of surgery. And no one actually sort of, acknowledged where the problem was and then offered an apology for it. So they actually go to those ethical concerns that we have. And this occurred to hundreds of thousands of women around the world in all countries, really.
Wanted to ask. Sorry,
I just wanted to say thank Melanie for her contribution, really, because that is the other side of this recognition question. It's not just about a recognition by those involved in a harm that something has happened. It is also a recognition of the harm and the impact that has, and the opening up of that, and the almost the validating of the things that patients may have just been feeling or may have tried to raise is a very important point to acknowledge.
Your report refers, and this is on a different topic, to what you've described as the transformative effects of global pandemics, which is obviously a highly topical issue in the current circumstances. Can I ask you, first of all, the extent to which you can assist us with understanding, from your perspective as ethicists, how the HIV pandemic shaped the development of ethics or new standards? Professor Cave?
Yeah, I don't mind starting off on this one, though I'm sure there'll be many points that could be added to what I have to say. Well, HIV was one of the most serious public health challenges that we faced. And as we know, treatment has vastly improved, but it's not over. There's still problems with diagnosis coming too late, with in many cases. There's still fear, there's still stigma, there's still ignorance. At first, there was no treatment on the horizon, so the focus was on prevention. And then there were efforts to develop and to scale up the treatments, and a lot was learnt there about various things, including one important point was the ethics of trials in developing countries and duties to subjects, which we now call participants, and that's very telling that we've changed that term. So, for example, some pregnant women were denied certain drugs in order to make for a scientifically rigorous comparison. So we'll explore this later when we look at research, but we learnt an awful lot due to this pandemic about the ethics of research in this country and in other countries. And then there were other issues around putting collaboration and speed in developing treatments over commercial interests. So the fact that pharmaceutical companies came together to some degree, and we're seeing this very well in the COVID-19 crisis, for example. But that became very important. Speed became important in trying to come up with tests and with treatments. So global cooperation, global funding, because this was a global issue. It wasn't something that each country could look at separately. We also learnt a lot about confidentiality, about transmission risk within families and workplaces and what ought to be done about that. And about stigma and the corrosive effect of stigma and how we might help to deal with that. So that's a starter. I'm sure there are many other issues which others might be able to come up with.
That's a brilliant start. I remember those. I think we've used the term social movement before, and I think the HIV and AIDS pandemic gave birth to a social movement that was very influential, both in terms of driving the research agenda and speaking to members of its own community about their responsibilities to engage appropriately with that research agenda. In those early days when there was no possibility of an effective cure, people were doing whatever it took to try and get some hope, travel out of America across the border to Mexico to buy unlicensed, unevidenced drugs. And it was actually a movement within the HIV community that said, no, we've got to do this properly. We've got to take part in these trials. We've got to do the right thing in order to help build the evidence base. So there was a sense of personal sacrifice, which was probably well advised anyway, but nonetheless, at a time when everyone was so desperate, there was a sense that people had to come together to help the scientists and the doctors find ways of effectively treating this condition.
Could I add to that? Because I'd agree with everything that Emma and Bobby have really eloquently described. And in many ways, it really can't be overstated. It's to give a quick example from Sydney, because in many ways, in the West at least, the HIV pandemic emerged on the sort of west coast of the United States and east coast of Australia, because they're very much sort of sister cities and so forth in that sense. And the initial research that was being done entirely to the established paradigms and timelines of research. These will be slowly generated, placebo-controlled studies that will generate products over 3 to 7 years. And what happened is in both in the United States and in Australia is that the HIV community got together and they said, let's pool our medications and we will share them out ourselves. And that way we'll increase the likelihood that more of us will get some active product. Now that completely destroyed the initial studies. But the point was that then it's said to the research community, you have to design research trials and clinical trials in collaboration with the end user or the affected community. So it actually spelt an end to the days where research could be designed entirely without any consideration of the community that was impacted upon by this disease, the target community, if you want. And so that aspect of collaboration really transformed research. To a lesser extent, I think it changed other areas of practice, public health and clinical medicine, but it did change those as well. It certainly fomented shared decision-making and collaboration and shared care, certainly did that. And in public health, in some countries at least, the engagement of the HIV community, the gay and lesbian community in designing public health campaigns, those countries that did do that were far more successful in inducing sort of primary healthcare measures to actually control the pandemic. And again, there are some lovely examples from the United States and from Australia of public health campaigns which were co-designed with the HIV community. They were incredibly successful. So I think it was transformative in a range of different spheres. Research, absolutely, but also in public health and in clinical practice.
I want to next ask you to explain two concepts you refer to in your report, and it's really for the benefit of our audience. Moral relativism and moral objectivism. And I wondered if you could tell us, first of all, perhaps in a nutshell guide, what's meant by those two phrases. And then I just wanted to ask you to clarify a couple of points in your report after that. Professor Phostides?
Okay. Well, if we start with moral objectivism, that is the claim that we can say some things about morality, ethics, what is right and wrong, that are analogous to facts of the matter to a certain extent, in that they're stable, they're widely applicable, they're not dependent upon the context within which you currently exist. So if we feel that there is the possibility of setting up universal principles that hold over time and place, then we are leaning towards a more objectivist view. The way that might be challenged is by those who say that actually our moral values are a product of the society within which we exist, or the society which we are looking back to or across to if it's in another country, another cultural group. And as such, we have to take, in order to be consistent, a more laissez-faire attitude towards values or standards or principles that look different to our own, because the explanation might justifiably reside in the difference in culture, religion, time, etc. So if you are a moral objectivist, you are looking for some level of permanency and universality that you would not feel confident to find and in fact would certainly challenge from a moral relativist perspective. I hope that's clear. It's a complicated issue.
Can I add one thing to what Bobby said? There's another distinction which I think is very important in this debate, and that's between moral relativism and context specificity. So what can be right in one context can be wrong in another, and that doesn't mean that you don't have some universal or moral objectively true principle in both of them. It means the facts are different. So to give you an example, freedom of movement is important. However, in a pandemic, people have less freedom of movement because there's an existential threat. That's different to saying, well, freedom of movement is only important in societies that happen to value it. It's not important in those societies which don't grant freedom of movement to their people. That's a moral relativist position. Context specificity says freedom of movement is always important, but how important it is will depend on the facts of the circumstance. And moral relativism, in my view, is really like moral nihilism. It's like saying, well, there's nothing really wrong with what the Nazis did. They just had a different set of morals to us. We can't really criticise their society in any robust or morally objective way. But really, we think that torture of innocent people is wrong, slavery is wrong, regardless of whether society, a particular society at a particular time, condones those things. But the moral relativist is bound to say, well, you know, slavery, it's right in certain societies or in certain cultures or at certain times.
And in the clinical context, your report identified two examples of once accepted practice that in your words, horrify us today. The first was pelvic examination of women under anaesthetic at training hospitals without their consent, the idea being that this would further the education and development of skills by doctors, as I understand it, which today, as you say, would be condemned as a violation of bodily integrity and a gross breach of trust. And the second example you give is the Alderhay Hospital, the retention of organs without patients' or parents' knowledge and consent. I've been asked by call participants, I think, to perhaps clarify something in your report. Some call participant questions have read this part of your report as trying to excuse the practices of the past by saying it was a different time. I'd rather read your report as saying the opposite of that, but I wondered if you could clarify what you meant.
I'm really sorry if we haven't been clear on this point, because I think we were absolutely supporting the type of point that Julian's just set out so clearly, that there are certain things that happen where, when it happened in terms of time and space, are not going to excuse them as because we have a fundamental belief that moral wrongs and harms were entailed in what was done.
Yeah, and that's not to say that that context and history are irrelevant. It's not a binary. I think and maybe this is why possibly it's not quite as clear as we wanted it to be, because we are trying to say is that there are ideas or principles or ethical norms that are incredibly stable across time. They're incredibly shared across cultures, as Julian said eloquently in our earlier session this morning. They are things that we value, you know, irrespective of where we live or the cultural grouping that we're part of or the community that we're part of. These are things that we think are important and they are core to our existence as human beings. But by the same token is that the context in which we live, the historical norms at the time, the power structures that exist, the circumstances of our own life at the time, so they undoubtedly interact and determine how these things play out. And in medicine, as in many other spheres of life, we can see examples of practices and behaviours that at one particular point were deemed acceptable, but subsequently with further thinking, sometimes, and it's just with further thinking, it becomes clear that those are just not acceptable and were actually never acceptable.
To give an example of today, it's possible that in the future people will look at our practices towards animals as we look at people's practices towards slaves in the past, or they may look at our practices of buying products from sweatshops in the same way as we look at, you know, industrial revolution practices involving, you know, poor workers. So, you know, ethics is demanding, and by no means do I think that we've got it right today and that we're living these, you know, perfect lives. I mean, we may be as criticisable as people in the past. So I think it's important to recognise that you know, we can all fail and can be failing now without us knowing it or acknowledging it.
Is this correct, or is this too much of an oversimplification, that context and history, as Professor Kerridge has just referred to, might help us understand why something happened, why a practice took place, but won't necessarily provide a justification or excuse for that practice having taken place?
That's exactly right. There's a distinction between two kinds of reasons: explanatory reasons and justificatory or normative reasons. So something can be an explanatory reason, without it necessarily justifying it. And often those two kinds of reasons are run together, but they're completely separate. One is descriptive and one is ethical or normative.
That's the value of ethical thinking, because if applied rigorously and applied to a particular practice, even just one that raises a question, it doesn't have to be sort of clear that it's wrong. It just raises a question about why this is being done. By applying sort of ethical thinking or systems of reason and logic to it, then sometimes what can happen can be a complete reversal of practice. You know, to give an example of one where, in fact, it was a philosopher or a series of philosophers that changed practice. At one stage, it was standard practice that when children are born with Down syndrome, so trisomy 21, and they also would have a thing called duodenal atresia. So this was a congenital malformation where the bowel ended at the duodenum, so the first part of the small bowel. So the standard practice was for those children to be just left to die, and essentially, so they were starved to death, and that was believed to be appropriate and good caring paediatric care or neonatal care, but eventually, both from physicians and also from moral philosophers, people said, well, what would you normally do if a child didn't have Down syndrome and they had that congenital malformation of the small bowel? And the answer was, that's actually quite an easy thing to fix surgically. We would fix that quite easily. It can be done very quickly, and then these children do incredibly well, and they really have no long-term consequences of that particular malformation. Easy. And then the obvious follow-up question was, well, then the thing that's of ethical concern here, and the reason that you're allowing this particular child to die, is because they have Down syndrome. So we need to ask whether that's acceptable. And then when people looked at it, they said, actually, that's not an acceptable basis for making that decision. It may be relevant in other circumstances, but it's not a sufficient ethical basis to justify that decision. And the whole practice of management of children with that congenital malformation in that situation changed. And it was just through thinking about it properly and logically.
Now, it's clear, I think, from everything you've said so far this morning that a clinician's primary consideration is the best interests of their patient. Are there any circumstances in which the duty owed by a doctor to the patient should fall secondary to other considerations? And if so, what are they?
Well, I mean, I can start. I mean, in a public health emergency, doctors will then have other considerations and other patients to consider, where the law requires them to take into account other considerations. Then they may have to put aside their duty to that particular patient. But barring those sorts of considerations, the doctor should be focused on their patient.
And those situations are uncommon, and even within the setting of a pandemic, if there are broader rules developed above the bedside, if you want, then they come into play rather than the individual doctor, who arguably can still be working in the best interest of their particular patient. They may not be able to achieve what they want for that person because of these more overarching public health principles, but they could still be doing it.
I mean, a mini example of the pandemic sort of kind of criterion is also where there is a clear duty of rescue to other patients. So this has been a part of the duty to inform of either violent threats of patients with psychiatric conditions to specified other people, or indeed the duty to warn of infectious diseases. That's where there is a clear and identifiable person who could be affected as a result of the care of this particular individual. But again, those are rare considerations.
Yes, that particular one is one I think we'll come back to.
Sorry, I wonder if we should quickly address the issue of where a decision has been made in a different place. For example, an allocation decision that means that a doctor is unable to do what a patient considers to be in their best interest. And you might think, for example, a drug that NICE has deemed not to be cost effective and therefore not available to all patients. And in that situation, I think what happens is the list of responsibilities that the doctor has in order to further the patient's best interest to the extent that they can in that situation shifts to one that is more about communication, empathy, being clear about any alternative ways of accessing the treatment if that is thought to be a responsible thing to do. So there's a sense in which increasingly patients have a very good sense of what might or might not be in their best interest, and it's not always deliverable. And then there is a particular responsibility on the clinician to deal with that difficult occasion.
Professor Cave, was there something you wanted to add?
Yes, just briefly, and that is that today there's a lot of assistance when it comes to making those resource decisions, because there are bodies such as NICE that work out what medicines ought to be prescribed in a given situation. But in the past, that was not necessarily the case, and perhaps on an individual basis, resource decisions had to be made by physicians at the bedside, which is a much more complex matter.
Could I just add to the example that Bobby's raised, because I think this has actually become much more complex in the last few years. In the setting of a single unifocal healthcare system with which is publicly funded and publicly run without a significant private healthcare system and so forth, and when there is only one source of information about therapies or medicines, it's relatively straightforward to say, look, this is what's available, this is not what's available, done, end of discussion. But increasingly, practice for clinicians now involves a more nuanced discussion, and it may be something along the following lines. There are a range of different therapies that are available. These are the things that are accessible through a publicly subsidised funding system for access to medications. Then there are other medications that may or may not have different levels of evidence that you can't access through through the standard pathways of access. So in which case, what's open to you? What's open to you may be paying for it yourself, seeking funding from other sources, whether it be a health district or a hospital body or crowdfunding, or seeking it as part of a compassionate access program or an individual patient access program from a drug company, which comes with its own set of problems, or trying to find a clinical trial, not in order necessarily to advance scientific knowledge, but actually to get access to that medication. And all of those things, patients are much more aware of now, and will actually foment that discussion, even if you're not willing or feel nervous about going into that territory. That happens, and that's happening increasingly.
Now, the questions I've asked you so far focused, and they'll continue to focus on the ethical responsibilities on clinicians in the sense of doctors. Can I just ask you to assist with this? To what extent do the ethical principles and the general approaches that you've identified apply to other healthcare workers, such as nurses or medical scientists? Professor Pharsidis?
I feel a certain confidence in addressing this question because of my research, which has not just been with doctors, but with nurses and allied healthcare professionals and laboratory scientists. And I think there's an increasing awareness of the moral responsibilities that individuals carry when their work touches upon people's health and well-being and continued life. In some areas that has become just as well developed in terms of guidance and protocols. In others, less so. And I would say probably in laboratory science, we've been quite slow to give people the same sources of reference that you might have as a nurse or a doctor, or indeed as a physiotherapist or an occupational therapist. But that doesn't mean that people don't grapple with ethical issues. And certainly when working with people in stem cell laboratories, in embryology services, you find that they are as much part of the multidisciplinary team as others when discussing ethical boundaries, things that the team would or would not find morally acceptable to offer or be involved in. And more recently, I think I've been struck by how in the field of genetics and genomics, the people whose day-to-day work is actually carrying out the tests and then passing those results back to clinicians who are seen as the ones that will impart the information, there is a concern about what is looked at, how it's looked at, and how you, in a sense, frame or create a result out of what has happened in the laboratory.
Can I add, sorry again,
Yes,
to add to you?
not at all.
A sort of basic ethical principle that I think is relevant in this context, and that is the principle of ought implies can. To say that somebody ought to do something, it presupposes they can do it. So in the area of research, I've argued that, for example, in neuroimaging research, doing MRI scans as a part of research, neuroimaging neurologists can have a duty to report back incidental findings to participants. But that assumes that they can, and can here also means within the constraints of distributive justice. That is, how costly is it to it? How difficult is it to do it? So in many cases, all of us owe ordinary obligations to people. Now, whether we can meet those depends on the constraints of the situation. But if you can do it and do it relatively costlessly, there's a duty of easy rescue to do it. So the duty of easy rescue is the idea that, and this in my view is the most minimal ethical principle that applies to all of us, is that if the cost to you is small and the benefit to somebody else is large, you should do that action. Or if the cost to you is small and the harm averted to somebody else is very large, you should do it. And so that applies not just to other health professionals, but to everyone.
The last general topic I wanted to ask you about before turning after lunch to the question of informed consent, it's about what we've heard referred to by some of the clinicians who've given evidence as the precautionary principle. And indeed, I think we've heard government ministers use that term in recent days in the context of the current pandemic. Is that a principle which you recognise as ethicists? And if so, what can you tell us about it?
I'm happy to start. So that is an ethical principle. It's also an organisational principle in public health and epidemiology, which is sort of where it has its genesis, really. It's not a straightforward one, and there's at least sort of 7 formulations of the precautionary principle that I know. So it's the idea that if there's an identifiable risk, then we should take steps to avoid that risk. And this is a risk of an adverse event happening in the future, that we can take steps to avoid it. The problem there is that there might be questions about how foreseeable that risk is, how significant the risk is, what strategies are available to reduce that risk, and what's the cost of those strategies. So what we lose by introducing those strategies. So there may be a risk that's 1 in 3 million, 1 in 13 million, 1 in 15, 1 in 20 million of an infection related to the blood supply. And we could get around that risk by expelling 1/2 of potential blood donors, or by introducing a new test looking for a particular infectious marker and so forth. That by doing those strategies, they may be affordable, but equally they may bankrupt a health sector. It may strip a blood supply of its capacity to rescue people in dire circumstances. So there will have to be value assessments made about the risk, about its significance, its prevalence, its salience, about what can be done to avoid it, about what should be done to avoid it, and about what is lost by taking steps to avoid that. And there's been a range of examples relevant to this inquiry and subsequent to the HIV epidemic and the infection of people with hepatitis C and hepatitis B from blood that have raised questions about the precautionary principles. So I think it's important, but it's complex.
So the standard way people make decisions in ordinary life is you look at the options, you predict the sort of harms and benefits and the chances of them occurring, and you maximise what's called expected utility. And you choose that option which has got the best balance of benefits over harms adjusted for their probabilities. That's how you decide how to buy a house or a car or whatever. So the precautionary principle, and I agree with Ian that there are at least 7, probably 20 different definitions. The precautionary principle, insofar as it's plausible, is not that we should avoid any harm because that would mean life stops. It's the idea, I think the most plausible version is when you're at a very high level of well-being or you're well off, and one option means you stand to lose all of that or a substantial proportion of it. Even if the chances of that happening are extremely low, you might choose not to take that option because you stand to lose everything. The loss is so grave. So, for example, existential threats. So, for example, from biological weapons might be very, very unlikely. And expected utility theory might say we don't need to try to avoid them. But because they're so devastating, we might expend extra resources on them. So sometimes the loss is so great, we ought to deviate from standard expected utility theory. But this can be abused. So, for example, the sort of threat from genetically modified organisms was used as a basis for banning them in Europe. And in my place, that was a mistaken application of the precautionary principle because there really was no chance of an existential loss in that case. So the precautionary principle can be abused, but I think there can be appropriate places for it.
I agree with both of you. And I think one of the important things to think about is who is engaging the precautionary principle and on what basis are they quantifying or, more importantly, giving a qualitative account of the risks involved. And it's another issue that plays into the importance of openness and transparency and communication and collaboration, because the rather nice example Julian offered of choices we make in our own life, not to sacrifice or even put at risk our well-being for something that might have substantial risk associated with it, is fine. But if someone else decides on our behalf and we have no knowledge of whether their assessment of risk is accurate, whether the risks are ones that we see as particularly pertinent to whether our life will go well or not, or our future is open or not, then it's problematic. So I think we can think differently about a precautionary principle that is adopted in an open and collaborative manner, and a precautionary principle that is pulled in to justify decisions that were taken on a very narrow sense of risk as enjoyed by another person who has not been consulted or engaged.
Could I just follow up from Bobby's point there, because I think that's so important. The idea of the definition or understanding of what a risk is and what a risk means is profoundly determined by who's making that assessment and on what methodological grounds they're doing it. If I can give a brief example, when there's discussion based around what public health measures need to be put in place to deal with peanut anaphylaxis. Right, so this is, children classically are exposed to peanuts and can have very severe allergic reactions, including those ending in death, principally from suffocation. So if you go to some epidemiological accounts of the risk of peanut anaphylaxis, they're stated in purely numerical terms, and they'll say, look, in different parts of the UK, the risk is, somewhere from, 1 in 30,000 to 1 in 300,000 of significant peanut anaphylaxis causing death in children. This is a risk that needs to be considered, but perhaps it's not too much of a concern. If you actually go to narrative accounts of mothers in particular, whose children have severe peanut allergies and have had experiences of peanut anaphylaxis, is that they say is that, I watched my child when I'm trying to feed them, and nourishing one's child is one of the principal things you can do as a parent. I'm trying to feed my child and they go blue and they drop in front of me and they look like they're going to suffocate and they're severely distressed. Any measure to avoid that happening becomes justifiable, because the risk is so profound and its perception of severity is so profound and seen very differently in totally non-quantifiable terms.
Can I add to this? I think this is central to your inquiry, Bobby's point and Ian's point. It's about how to value risk. And in relationship to the case of Charlie Gard, I've given this example to many people, but I think it illustrates the point. So say you've got a condition, you're going to die, but you could go to intensive care and you'll need at least 3 months of intensive care with painful procedures, maybe, a psychological upset. You won't be completely sedated or anaesthetised. And at the end of that, there's a 1 in 1,000 chance that you will return to a quality of life you find acceptable. Do you want to go through intensive care to have that 1 in 1,000 chance? When I've asked professionals, lay people, roughly half want to take it, half don't. Now, there's no right answer to that question, because it's about how you personally evaluate that risk. That's not moral relativism, and this is very important. It's not to say that risk is purely in the eye of the beholder. It's that ethics is not black and white. It's black, white, and grey, and this choice is in the grey zone. There isn't a right answer to whether you should, have that intensive care or not. It really depends on how you weigh up the probabilities, the risks, and the benefits, and that is central to much of everyday life. And central to evaluation of medical risks as well. So that's why the most important way to evaluate a risk, ideally, is that person themselves evaluates it, because people will legitimately disagree on the same probability for the same outcome.
That leads perfectly to the topic of informed consent, I think, which we're going to touch on or come to in some detail after lunch. So I note the time, and that may be a convenient point at which to stop.
Well, I just want to ask perhaps a couple of questions, if I may, for whoever wants to take it on. We've spoken quite a lot about the best interests of the patient, and I just want to be clear: who, in your view, decides what is in the best interests of the patient?
I think for me, if the patient has capacity, and then it's the patient themselves can determine what's in their own best interests after receiving sufficient information about their situation and therapeutic options that are available to them, then I think they're certainly best placed to make that judgment, because it's principally a judgment based on their life circumstances and their values.
I would respectfully disagree. So this is going to be, I think ultimately it's the responsibility of the doctor to decide what's in the best interests of the patient after dialogue with the patient about their values, their life circumstances. But sometimes patients can request something legitimately that the doctor doesn't believe is in their best interest. So I gave you the example of breast cancer treatment. A doctor may believe that it's in the best interest of the patient, even after hearing the patient's values, that the patient have surgery, radical mastectomy, radiotherapy, and chemotherapy. And the patient may say, well, I've heard all that and I want just the lumpectomy and the radiotherapy for these reasons. And if that's a legitimate option for the patient, it may not be in their best interests, but in this case, it's out of respect for their autonomy within the constraints of the system that we should provide that treatment to them. I think autonomy comes apart from best interests. Some people bundle them together and say whatever an autonomous person wants is in their best interests. The problem with that is you're stuck with this judgment that a Jehovah's Witness who's refusing a life-saving blood transfusion, when they know all the facts and have thought about it clearly, it's then in their best interests if that's what they want. I think you don't give them a blood transfusion out of respect for their autonomy, and it's against their best interests, but nonetheless, that's what you should do. So I think ultimately best interest is separate from autonomy.
Could I add that I think that best interests... Oh, sorry, Ian.
Sorry, go on.
First. I just wanted to add that the best interests of the patient are... Decisions are made at lots of different levels. So, for example, government bodies will decide whether to license treatment, whether to license a treatment is in the best interest of patients generally. Protocols are set out as to which treatments should be resourced. So they are, in a sense, best interest decisions. Is it best for patients to have these things? And then at another level, doctors are making, or clinicians, healthcare professionals are making best interest decisions about what options to put to a patient. And then at another level again, patients are deciding which of those options are best for them. So I think the question is best interests in relation to what sort of decision, because there are various ways in which those decisions play out.
I think, I take on board what Julian says. I think most of the time, in fact, people's decisions about what constitutes their best interest will concur. So most of the time, I think, because doctors do make decisions about what is in somebody's best interests, family members will make decisions about what they believe is in their parents' or their siblings' best interests. Lots of other parties will make these decisions as well. Most of the time, there's agreement. There are some times that there is profound disagreement, and in those situations, at times the support will not be in the favour of the patient's assessment, or will not be in support of the doctor's assessment of what is in somebody's best interests. And there has to be mechanisms for determining how to resolve those conflicts. And at times we resolve it in terms of the patients. The example of Jehovah's Witness is a good one. I think an alternative idea is that you include respect for autonomy as part of best interests. But the alternative formulation is to say that we respect autonomy independent of a judgment about best interests as well. But there'll be other decisions where we would rule against a patient's decisions. That's a claim for a very expensive therapy or for ongoing care that is judged to be futile. So I think it is made at different points. Most of the time there's agreement. At times there is profound disagreement.
To add to that, best interest is something that will depend on the person making the decision. So traditionally, the purpose of medicine is to save life, to preserve life and health of the patients. But what a particular patient sees as best interest to them might not be the same as another patient or the doctor's assessment of what is in their best interest. And what we might see as an irrational decision for someone's life, from their perspective, is different from what we would see as irrational for us, or as a rational decision for ourselves. And this depends on the patient's background, the patient's identity, the patient's religion, culture, and other things. So I think best interest will depend very much on the individual and on the situation. So on the diagnosis of the person, if that person is suffering from a life-threatening disease, for instance, if they have different options, And this links to the issue of informed consent and autonomy, because we might give people choices by telling them that they have a particular disease, but maybe that person thinks they would have more choices if they weren't told of that particular disease. So what they see as their best interest is not to know, and that would differ from person to person. But I think we'll come to that a bit later when we talk about informed consent.
May bring me to the next question, which I was going to ask, and I think Professor Cave may have answered it to some extent anyway. How do you reconcile the best interests of the patient, if that is for the patient essentially to determine, with the best interests of the community of patients of which he is part? We've talked a lot about rights, individual rights, particularly after the Last World War. Collective rights or collective interests, do they have a part to play?
I think that's a really good question. I had reason recently to have a look at the NHS Charter again, and I was very struck by how it is still very much crafted in terms of patient rights. And even though we as ethicists increasingly think about these communal responsibilities and the extent to which maybe the demands that you make on a health system should be made minded of the opportunity cost that might entail for other patients, or minded of the fact that they might not always be met. The language very much almost encourages us to think about ourselves as right bearers rather than obligation bearers. And sometimes people have made themselves quite unpopular by choosing as their topic of inquiry what the responsibilities are that you have as a patient. But I think, again, the current pandemic is showing us in very stark terms that if we don't acknowledge certain obligations and, more importantly, fulfill them, and if the state doesn't set up systems that enable us to fulfill those obligations, we find ourselves in a much poorer situation.
Does anyone else want to make a contribution? I'm sorry, I'm taking you away from your lunch, but perhaps the best thing to do is, if we need to, is to come back to it at what will now be 2:10. So let's do that rather than take up any more time now. Thank you very much for this morning. Do we lose you here, I think, Professor Kerridge?
I think it's likely, otherwise I'll be no use at all tomorrow either.
Well, I thank you very much for being here past midnight, and I look forward to seeing you tomorrow evening for you.
Yes, no, thank you. I've enjoyed it immensely.
Thank you.
Thank you, sir.
So 2:10.